This is Audible Bleeding, the Vascular Surgery Podcast. We're here to help you keep your finger on the pulse. Welcome to the first episode of Audible Bleeding. We are honored today to have Professor Frank Veith on for our first episode of Audible Bleeding. Dr. Veith is a professor of surgery at the Cleveland Clinic Lerner College of Medicine, and he's also a professor at the New York University Medical Center. He additionally occupies the William J. Lieberg Chair in Vascular Surgery at the Cleveland Clinic Foundation. In 1993, he received the National Institutes of Health Vascular Disease Academic Award, and Dr. Veith is known for authoring over 1,000 original publications and chapters in medical journals, particularly on limb salvage surgery and more recently in the fields of endovascular grafting for traumatic and aneurysmal disease. He's the past chairman of the American Board of Vascular Surgery, the past president of the Regional Eastern Vascular Society, and served as the 50th president of the Society of Vascular Surgery. Additionally, he graduated from Cornell Medical School, which is where this podcast is being broadcast. Dr. Veith, we are honored to have you on our first episode of Audible Bleeding.
Okay, it's a pleasure to be with you.
So, Dr. Veith, we just wanted to dive in, and I know you had a little bit of a roundabout way in deciding on vascular surgery. Could you just tell us how you ended up deciding on vascular surgery for your career?
Well, originally I trained at the Peter Ben Brigham and Harvard Medical School in general surgery, which really was general surgery. It included cardiac surgery, GYN, orthopedics, everything. Vascular surgery was very much a small subspecialty at that time, and there was really no training programs, or perhaps one or two. But I guess I decided to focus on vascular surgery because, number one, it was challenging. Number two, it was fairly clean, and I guess I liked it. It also was related to transplant surgery because of the requirement in transplant surgery to do vascular anastomosis. So the two are connected, and I guess my specialty training, if there was one, which was rather unique at the Brigham, was in transplant surgery. So I began to focus more and more on vascular surgery after I left my training and moved to New York.
Dr. Veith, this is Sharif. What are some of the important decisions that made you successful over the course of your career?
First of all, there's some luck involved. Secondly, I sort of chose to focus on things that were not popular or went against the grain, areas that other people felt were either impossible, challenging, or wouldn't work. That certainly applied to limb salvage. It was a no-no area. We got into it and found that it worked. The vascular surgical revascularization procedures worked, although we were treated as mavericks in the beginning and thought to be a little crazy. Gradually, people saw that they too could make it work, and so that gave us a leadership position in that area. That was also true of endovascular. In the beginning, people said that we were out of our mind and only going to drag vascular surgery down to explore these ridiculous procedures, and they turned out to work. That allowed us to be leaders in areas that were originally thought to be either difficult, impossible, or not appropriate. And the other thing I think that enabled me to accomplish some things was that I was able to build a group of vascular surgeons that was coherent and worked together in a very effective way. And one of the reasons we didn't fight amongst ourselves, as many type A personalities want to do, was that we were constantly being attacked in the institution we were at, either by general surgery or by our administration. We were an embattled group of people who were forced to stick together by the adversity of being opposed and picked on by both general surgery and our administration.
Dr. Veith, one question I had for you is back to the limb salvage and being a pioneer in that. Can you discuss kind of what the landscape was back then as far as options for limb salvage and in what directions you guys pushed it?
Well, basically, this was going back to probably the very late 60s or early 70s. The standard treatment for gangrene or ischemic ulceration or rest pain was an amputation because it was felt by the San Francisco group, Jack Wiley's group, and by most others that revascularization procedures didn't work and only led to higher amputations and a lot of grief. And that was because they'd been tried prior to are getting involved and been found to be largely unsuccessful and indeed harmful. So when I went to Montefiore in the Bronx, of course, I, like every other young vascular surgeon, wanted to do aneurysm cases and carotids and the sort of glamorous things that were around in vascular surgery. We didn't have many candidates for those procedures. They all went to Manhattan and the more prominent institutions, but we sure had a lot of patients with gangrene and ulceration and ischemia, often with diabetes. We, in the beginning, figured, well, since we had so many of these patients, let's try to save some of these limbs in these old sick patients. We found, much to our surprise and delight, that some of the procedures that were thought to be impossible, namely doing bypasses below the inguinal ligament, we were able to make them work. We were therefore emboldened to try more and more to do more distal bypasses, and they too, when done with great care and diligence, worked. The other thing that really helped us a great deal, the arteriograms of the day. This was back in the 70s now, and probably extending into the 80s. The arteriograms of the day would end just below the knee or in the mid-leg. And we had really good arteriography. I at that time made a mistake, I guess. I stopped the surgeons from doing arteriography and gave the procedures to our radiology colleagues. And they just got fantastic arteriograms, which showed the vessels down to the toes. Frequently, a patient who had no reconstructible target artery anywhere in the thigh, leg, did have a patent artery in the lower leg or foot. And we began to use those for bypass targets. And much again to our surprise and delight, if we did them very carefully, mostly with vein grafts, they worked. And that really enabled us to accumulate a large experience in limb salvage, which we presented at various places, including the American Surgical. And we were thought to be out of our minds, crazy, want to do this nonsensical stuff. But it did work. And over the years, more and more people got into the game. We also were the first to use angioplasty and stents amongst vascular surgeons because they felt that they were bastard procedures that wouldn't work. So we sent our interventional radiologist out to Daughter to learn how to do angioplasty. And much to our amazement, when we brought them back in these old sick patients, they worked, and they allowed us not to have to do very many aortobifemoral bypasses, which were the glamorous procedure of the day, but also in our old sick patients had a pretty high morbidity.
Dr. Veith, this is Matt. It's interesting to me that you talk about carotids and aortas being the more glamorous procedures. It sounds like some things never change. But also, it's interesting as a trainee to hear you talk about kind of the progression of moving down the leg for advancing bypass and limb salvage. It seems like that's where we're going with endovascular treatments, or where we're have recently gone with endovascular treatments. Do you feel like that's a natural progression?
Yeah, I think it is. We were very fortunate. We got involved in angioplasty early because we had so many old sick patients that we didn't want to do big operations, and they had combination of not only aortic and iliac disease and lower extremity disease, multi-level disease. One occlusion of an artery usually doesn't result in a threatened limb. So the people that had threatened limbs, gangrene, ulceration, rest pain, usually had multi-level disease. And doing an aortobifem and then a 3 or 4 or 6 hour bypass below the inguinal ligament, that wasn't a good thing to do, and had a great morbidity. So we early on embraced angioplasty, way back in the early 80s, or even in the 70s, I think we started them. And at that time, they were very primitive. Before balloon angioplasty, there were what we call daughter angioplasty with tapered catheters. And then balloons came along, and then stents came along. And of course, we embraced them, and every other vascular surgeon thought we were out of our mind. We didn't have, I was going to say, cojones doing these ridiculous interventional procedures, but they did work. So we were lucky there to get into that game early. And that even enhanced our ability to save limbs, and also enhanced the reputation that we had of being somewhat maverick, iconoclast. But most vascular surgeons like to operate on big arteries. They're easier to sew. They're easier to dissect out. They're not as difficult. Operating on tiny little vessels really required a great deal of care and diligence. But again, if done carefully, the bypasses to these little vessels worked. And the other thing that we embraced early on, because we were really the first to do reoperations or reinterventions when the primary procedure failed, as it almost always did ultimately, we embraced repeat procedures. And so even though we favored use of vein, we early on ran out of veins in these patients and were forced to use prosthetic bypasses, PTFE or Gore-Tex. Again, remarkably, that worked better than other people felt that it was going to work. And that's true even today. I happen to believe that Gore-Tex tibial bypasses can be very effective, again, in patients who don't have healthy veins. We were, again, against the grain and still are to some extent. But we believe that a PTFE bypass is better than a bad vein, and it's certainly better than an amputation. Doesn't always work, doesn't work forever, but I have one patient now who's 15 years after many, many other procedures with veins, has a PTFE bypass going from his common iliac to his perineal, and it's patent for 15 years.
I have a little bit of a philosophical question for you, because you said the recipe for your success has been having a good group of people who work together in the face of adversity and sort of push the envelope. And how do you decide how far to push? I mean, like you said, you set yourself up for a lot of criticism initially with certain things that end up panning out correctly. But it can be hard to predict what's going to work out and what's not going to work out.
And frequently things that are thought not to work are working because you don't do them right. For example, all the other hospitals in New York, including Cornell, NYU, Columbia, they just didn't have the patience or the commitment to make these procedures work, so they thought we were lying. Tony Imparato, a very famous guy, was president of the SVS, the chief of vascular at NYU. Socially, we were very, very good friends. Our wives were good friends. We visited each other. But he didn't believe me. He just said, "Oh, Frank, you're lying. You can't make that thing work." And yet we were able to. I said, "Come on up to the Bronx and we'll show you the patients," and so forth. And he never came, but because he had lots of aneurysms, carotids, and those were his areas of interest. He was a very good surgeon and he was a good friend. We were very much enamored with each other and socially very friendly. But again, he had enough work without doing this difficult, rather unglamorous stuff of operating on sick old diabetic patients with gangrenous feet. So we got a lot of patients from NYU after they deemed them not salvageable over the years. The other thing, my attitude, I was a lover of Winston Churchill and respected him greatly. And he once said and practiced the idea of never, never, never giving up, never give up. And we held that attitude about certainly our limb salvage patients, but some of the others as well. Of course, we were worried that being so persistent would result in lots of infections, which it did, more infections, reoperations. But we found ways to approach arteries in virginal fields so you didn't have to redissect a wound. We challenged a lot of the current wisdom of the day. And that was true with, it was thought you had to originate all lower extremity bypass from the common femoral artery. Well, that just wasn't true. And we started using bypasses when the anatomy was appropriate for doing that. And much to our delight and surprise, it worked. Now, everybody does that. But we were really the first to advocate that that was a possibility. Why? Because it allows you to use shorter segments of vein, which some patients might have. And interestingly, now it's well recognized that much of the limb-threatening arteriosclerosis is below the femoral artery, going down to below the knee, very distal disease. Shockingly now, there are endovascular means to treat these very distal arteries. We didn't have that in our day. We were the first to do tibial angioplasty, but we did it with very primitive coronary balloons and stuff. But now it's, routine. And they have these great balloons and great guide wires and stuff like that.
Dr. Veith, I think that leads in perfectly to my next question. I was wondering, now it seems like, new catheters and new wires, et cetera, are coming out, every 5 minutes, and we've got way more than we can even keep up with. But how was the, flow of technology back then? Was it a bottleneck, or was it also felt like you were getting new stuff all the time?
Well, there was always, something new on the block, and our industry partners, which were also another key to success. We were one of the first to recognize that the industry people are our partners, that we work symbiotically with them. Whereas in the early days, the giants of vascular surgery, like John Mannick from Harvard and the Brigham, they used to feel that industry was sort of a dirty colleague, that we weren't supposed to work with them because it was a corruption. He gave one of his presidential addresses on that. And at the time, we were working with them maybe because we were in a disadvantaged institution in the Bronx. We were working with industry very closely. And certainly in our CME work, having industry partners is great. They bring a lot to the table, both in financial resources and in engineering expertise. And without them, we couldn't do anything. And that's true both with open vascular surgery, but mostly with endovascular. Now, there's excessive use and development of unproven technology, but, that's part of the game. And some of it's going to work, some of it's not. Some of it may not work initially, like atherectomy, which we tried early on, and it was terrible. It didn't work. I'm not sure that it still works, but we have more and better devices, and certainly the cardiology colleagues that in many ways are very brilliant guys, they believe in atherectomy, I think even more than vascular surgeons. But it's evolution of technology that makes the difference. The early atherectomy devices, and we had something called laser atherectomy and smart atherectomy devices that were supposed to be able to tell plaque from normal arteries. They didn't work. They created nice big holes in the artery for a lumen, but in 6 months, all of them were closed, and they caused embolization. So what doesn't work initially may, with better technology, work later on, or with differences in technique. Again, that goes to the never give up idea, but obviously if something isn't working and you're causing patients harm, you've got to abandon it. We had some of that too. Interestingly, Enrico Asher and I tried early on to use arterialization of veins. And that goes back 100 years, that people have played around with arterializing veins as a way of revascularizing an extremity, and it hasn't worked. And it didn't work very well with us. A couple of times we had really surprising results where it seemed to make a difference if we destroyed the vein valves and stuff like that. And now it's reappearing with the new device for endovascularly arterializing veins.
On this topic, what do you think is the most important unanswered question in the field of vascular surgery right now?
Well, there's always been the challenge of stopping intimal hyperplasia because, as I said, all procedures fail ultimately. Much of the research in the early days was basic science to stop intimal hyperplasia. Now we have drug-eluting balloons and drug-eluting stents, which really seem to work. But I think that still is an unsolved problem and one that is a challenge. In my opinion, one of the most important unanswered questions is having an effective technique for picking high-risk asymptomatic carotid stenosis patients, because if you could pick out the ones that were at high risk, you could fix those patients, that is, do a carotid stent or a carotid endarterectomy. I think it's totally inappropriate to operate or stent most asymptomatic carotid patients because it's a benign disease. It's always been a benign disease. We never did many, even in the early days before statins. Early on, we had a vascular lab at Montefiore. We were one of the first. We took all these old, sick, atherosclerotic patients with threatened limbs, and we did duplexes on their carotids, and 2/3 of them had carotid disease, and we couldn't operate on all of them. We didn't want to operate on all of them. They didn't die from strokes. They died from heart attacks. And then along comes statins and some of these other drugs, and asymptomatic carotid disease became even more benign. You'll see this at our symposium. There are many, we have lots of debates. There are many that feel that no asymptomatic carotid stenosis patient should be intervened on. If you could pick the asymptomatic carotid stenosis patient that's going to have a stroke and just fix those patients, I think that's an important unanswered question.
I'm going to pivot a little bit, Dr. Veith, and maybe ask you to describe some of your failures or things that you've abandoned that you've learned.
Some of our failures, doing a Gore-Tex or PTFE bypass to an artery in the foot or at the ankle may work for a while, but we given that up in most instances. That doesn't work very well. And so that's one failure. But if one has a artery in the leg that runs to the foot and may run proximally as well, the procedure works there. But probably it's not going to work very well going to the foot. There are a lot of other things where we failed. Politically, that's the biggest failure. Not getting a independent board in vascular surgery was probably my biggest failure. It's a long story, and we felt way back in the late 90s that vascular surgery had evolved to the point, particularly with the introduction of endo treatments, that we should be a separate specialty, not under the control and direction of general surgery. And we mounted a very big effort to that end and came very close to succeeding, but we failed. So that I guess is my biggest failure.
What about advice for young, general surgeons that are interested in vascular surgery and young vascular surgery fellows? What kind of career advice would you offer for us?
Well, to some extent, I think I've touched on it a little bit. It's very hard for a young vascular surgeon to practice good vascular surgery alone. So I think you have to have a group that's cohesive and supportive. In the early days, we did a lot of the stuff alone, and that's not as good. So if you have a group of similarly thinking individuals, they can be men or women, obviously, that work well together, not easy, because there's always jealousy and stuff like that. But if you can eliminate that and have a group that works well together, I think it's worth being in such a group. It also helps a lot to have a mentor or senior person that can fight some of your political battles with you rather than a young person trying to fight it alone. I mean, it's, I guess, what I did, but it sometimes resulted in painful defeats. So 2 bits of advice: work in a group, typically with a mentor who you respect, who isn't trying to exploit you, which many mentors do. So you have to pick the mentor very carefully. And then work on dealing with unanswered questions. The tendency today, everybody wants to do thoracoabdominal aneurysms endovascularly. I think there are a lot of good people doing that. So try to pick something that's not as popular and where things aren't as glamorous. And those are the areas that typically you'll benefit from doing research in. And the other thing is pick an area where you're needed. If you join a group that's already full and you're the low man on the totem pole, it's hard to get very far.
I think that's great career advice. I'm still fairly early in my career, but I've seen it be very true what you say. What about with the upcoming meeting? Is there anything that you say that there can't miss topics or sessions that you would recommend people to go to?
A lot of people ask me that. The problem is the program is so good and so full that it's very hard one out. I mean, I think the lower extremity new techniques and so forth is very exciting. So is the carotid sessions. So are the thoracoabdominal, the conflict between parallel grafts and branched and fenestrated grafts. Those are exciting areas. There are also some new things on the horizon that Juan Peroti's talking about. If you drink water, you reverse the effects of arteriosclerosis. There are a lot of things. One of the aspects of our meeting, we were really the first to do this. We recorded the whole meeting. Since there are frequently 2 good talks going on at the same time, or you can't be there from 6:30 in the morning till 7 at night, even I can't do that. You tick off stuff that you want to hear in the program, and you get the library and look at the things that you missed, or you go back and re-review something that you thought was very exciting. But the whole meeting is pretty interesting. One of the reasons we've gone to simultaneous sessions, which I really don't like, because you have to pick one from another, you can't be in 2 places at once, is because there's so much good stuff out there that people are willing to talk about. But if you're really interested in getting the information, you can get it by going to the library. Now, nobody's going to listen to 1,000 talks. I think we have close to 1,000. But you can be selective in what you get from the library, and it requires effort. And, people don't read books. They don't read journals. They don't use our online library to the extent that they might. I think the online library is far better than a textbook. I mean, at NYU, we have monthly reviews of Rutherford's text, and I find that there's a lot of stuff that's in the text that's either outdated or plain wrong because it's outdated or the person presenting it has bias. I think a big meeting like ours where you get multiple views on the same topic I think that's healthy. But it takes a lot of work to go through it and to listen to it.
So, Dr. Veith, we have two questions we want to end the interview on. The first one is, what is something that's true that almost no one agrees with you on?
Oh, I think PTFE tibial bypasses. I think people still feel that that's something that should never be done, and we know it should be done. And as a matter of fact, some of my colleagues who are still at Montefiore and NYU and other places, guys that trained with me, we're trying to collect cases that Rich Neville from Inova in Virginia, Washington. We all have cases that where PTFE tibials have worked remarkably well for 3 or more years. And so Rich Neville is in the process of collecting and hopefully publishing that data. But most vascular surgeons would say you should never do a tibial artery bypass with PTFE. We know that they work if done with care, diligence, and a willingness to reoperate if there's a failure.
Absolutely. For our final question, this is a nice fall weekend in New York. What do you like to do on your time off?
Well, I don't get much time off presently. I used to really like skiing and windsurfing, but I've gotten to the point where now that's a little tricky for both me and my wife. We sail. We do a lot of hiking. We like good plays and good music. We like to watch some things on television. Either fortunately or unfortunately, with the meeting being what it is, there's not a lot of free time. But the things I mentioned are fun. We also like seeing our grandchildren and relatives, seeing them succeed. That's pretty gratifying. One of the things we don't do a lot, which I think we should, are movies. We saw an incredible movie last night of a guy free soloing up El Capitan, the big wall in Yosemite National Park. Yeah, incredible. I used to do a lot of mountain climbing. I never did it free, always ropes and stuff. But seeing this guy go up there was unbelievable. It was a great movie. It's called Free Solo.
You realize this is a little bit of a plant, but Matt Smith is a very accomplished climber.
It always amazed me, challenged me. I like to do things that are a little dangerous, windsurfing being one, skiing being another, but not to the extent. I mean, this was just remarkable. If you're a mountain climber, you got to see Free Solo. It's just amazing what this guy can do, and did. They made a movie of him doing it. I climbed the half dome, not up the front, but up the side. There were aids. There was a cable. So even though it was pretty steep, it was very safe. And I could look over at El Capitan and see it's just a granite wall. And this guy did it with no aids, no ropes, no nothing. Unbelievable. Seeing movies, good movies. There's a lot of crap out there, but there's some very good ones, and that's something we do because we can't climb mountains.
And I have to say that I think everything you've done in your career is just as brave.
No risk our life. The big risk in vascular surgery is failing to treat a patient successfully. And the most gratifying patients to treat are the ones that others deem unsalvageable or undoable. There's stuff appearing now on picking out ruptured aneurysms that you shouldn't treat at all. I find that wrong. I think that every criteria that would predict a high incidence of failure is not 100%. And we've saved some ruptured aneurysm patients, open and endo, that fulfill most of the criteria of inoperability, patients that have had multiple cardiac arrests. And a month later, they come in with a collar and a tie going to work. I would challenge that at present as trying to pick out patients that are undoable or have a high risk of failure. I find that goes against my grain. Don't give up on independence for vascular surgery. It's still important for a variety of reasons, as stated in the lecture I gave a couple of years ago.
And we'll put a link to that in our show notes so everyone can read your lecture. It is a great inspiring lecture.
Okay, we'll talk. Pleasure to do it.
We want to remind everyone that the 45th Veith Symposium is November 13th through 17th at the New York Hilton in Midtown. And if you can't attend this year in person, check out the online library of this year and previous year's Veith Symposium recordings at veithsymposium.org. We are Audible Bleeding, the vascular surgery podcast. Email us at audible.bleeding.podcast@gmail.com and find our full show notes at audiblebleeding.com.